Hello and welcome to the first video on adrenal anatomy and physiology. In this first video we're going to look just at the basic anatomy of the adrenal, the location, structure, the differences between the adrenal cortex and the medulla. We'll look at the blood supply, nerve supply, and a bit on the embryology. And then the next video we'll look at the steroid physiology, and then the last video we'll do a review of all the adrenal steroids. The adrenal, also known as the suprarenal glands, are located above each kidney. There's a right adrenal and a left adrenal, and again, this is patient's anatomical right and left. So the right adrenal is on by the liver, and the left adrenal is near the spleen. The different glands are shaped a little differently. The right adrenal is actually more pyramidal in shape. And we'll see that the different layers are slightly different in the right adrenal, and the left adrenal is more dome-like, dome-shaped. The adrenals, like the kidneys, are retroperitoneal, so behind the peritoneal cavity. They're wrapped in their own fascia. They have a very high fat content around the adrenal. In fact, the upper part of the kidney, the upper pole, is enveloped in fat, and the adrenals are sort of buried within that fat. They're yellowish in color, partly because they're very high in cholesterol. They're about 3 centimeters in width and about 5 centimeters in length, about a centimeter thick, and their combined weight is about 7 to 10 grams. So again, very small, but extremely important glands for regulating physiology. They're found within that fascia, which is named specifically the renal or perinephric fascia, and the fascia attaches to the glands to the diaphragm. So the adrenals and the kidneys actually move up and down with the movements of the diaphragm. So there's sort of a connection there with the breathing rhythm. We don't really take that into consideration in the physiology of the adrenals, but perhaps there's some interesting connections with that. And the adrenals are separated from the kidneys by what's called the perirenal fat. So that's the little fat that envelops the kidneys themselves. Very interesting fat. It has a very low melting temperature. So if you just hold the kidneys in that fat, it actually melts, usually in your hand. So it shows you this connection with the warmth and the warmth activities. The adrenals, we'll see, are connected not just to warmth, but also to what we might describe as is inner light. And I'll come back to that in a little bit. Again, the right adrenal is more pyramidal in shape. It's near the right lobe of the liver, and it's attached to the right crus of the diaphragm. The left adrenal is more semilunar, crescent shape, a little bit larger than the right, and it's near the stomach, the pancreas, and the spleen, and it's attached to the left crus of the diaphragm. Each adrenal has a connective tissue capsule around it, and then there's a cortex, the outer part of the adrenal, and this is what secretes the steroids. So if you look at, let me use the other marker here. If we look at this picture here, at the top, the cortex is this outer part, and then the medulla is the inner part, and this is where the catecholamines are secreted. They both have different embryonic origins, which I'll go over here shortly. But basically the medulla is an extension of the sympathetic nervous system and the neural crest cells, versus the cortex is derived from the mesoderm. The adrenals have their own veins, arteries, and lymphatics, as well as nerves. The veins and lymphatics leave the gland via a little hilum, and then that's a little indented area, and then the arteries and nerves enter at various sites into the adrenal. The sympathetic nervous system really follows the arteries into the adrenal. Just like in the kidneys, the sympathetic nerves wrap around the renal arteries and enter each kidney that way. So the majority of the adrenal is composed of a cortex, and that's about 90% of each adrenal gland. There are 3 distinct layers in the cortex, and each secretes different types of steroid hormones. Again, steroid hormones are all derived from cholesterol. These are the cortex is mesodermal in origin. Remember, mesoderm is what gives rise to all of your muscles, connective tissue, cardiovascular system, and kidneys. And that's what the cortex comes from as well. They're larger than the kidneys mid-gestation. So in embryonic development, the adrenals are enormous compared to the kidneys, and then they relatively shrink as the kidneys get larger. The outermost region of the cortex is the zona glomerulosa, and that lies immediately underneath that fibrous capsule. The cells form different groups. They have an oval-like shape, and they're filled with very wide capillaries. And the main secretion are the mineralocorticoids, and the main one is aldosterone. And this is activated, this is regulated by the renin-angiotensin-aldosterone system. Remember, renin is a protein secreted by the kidneys in response to perceived decreased perfusion or decreased sodium levels in the blood. That is an enzyme that is going to convert angiotensinogen from the liver into angiotensin 1, and then angiotensin 1 circulates to the lungs, and an enzyme called ACE converts angiotensin 1 to angiotensin 2, and then it's the angiotensin 2 which has multiple effects on the body. One effect is to release aldosterone from the adrenal cortex. Another is to vasoconstrict arterioles to increase blood pressure. And then the third is to activate the sympathetic nervous system. So all these actions combine to increase blood pressure, increase serum sodium and then water retention, and decrease serum potassium. So we'll see that with aldosterone secreting tumors, this is something known as Conn syndrome, C-O-N-N. A primary aldosterone secreting tumor in the cortex will raise blood pressure, will raise serum sodium, increase water retention, and decrease serum potassium. And that is a cause of secondary hypertension. All right, so that's the zona glomerulosa. The fasciculata is the middle zone, and that's the thickest layer. It's about 80% of the cortex. The cells are arranged more in columns. They're very lipid rich. They're called clear cells because of that. Very abundant in mitochondria, and that's partly because the mitochondria is the site, the primary site, where cholesterol is converted into pregnenolone, and then the pregnenolone is going to diffuse into the cytoplasm of those cells, and there are various steroidogenic enzymes which will create the downstream products. And the main one here in the fasciculata would be the glucocorticoids. So that would be cortisol, which is secreted, especially more in acute stress, corticosterone, and then the inactivated form of cortisol is cortisone. So it gets a little complicated. Another name for cortisol is hydroxycortisone or hydrocortisone. So you might see that label on, at the pharmacy for topical anti-inflammatory ointments, hydrocortisone. That's just the same as cortisol. When you remove that hydroxy group, then we just get cortisone. All right, so that's the glucocorticoids. They're regulated by pituitary ACTH, unlike the aldosterone, which again is under the renin regulation. And cortisone's main action is to provide resistance to stress, and it does that by basically acting catabolically to mobilize glucose, proteins, lipids, electrolytes, and water. So one of its main roles is to increase plasma glucose, and that's going to be through increasing gluconeogenesis, making new sugars in the liver, increasing protein breakdown, except for in the liver, but usually mostly muscle protein, and then increasing lipolysis. Now, you get a little bit of different effects whether or not the cortisol is released acutely or more chronically. So with high elevated cortisol, like in Cushing's syndrome, Cushing's syndrome is really having high cortisol, again, from any source. Cushing's syndrome. In Cushing's, you see the fat is redeposited from the peripheries, from the arms and the legs to the trunk. So you tend to get truncal obesity, but very thin arms and legs. So it has this weird effect of redistributing the fat. But that's more long-term cortisol. Short-term causes a quick release of fat stores for energy into the body. And then cortisol also decreases immune responses, inflammation, and inhibits repair. And that's really that these are very energy-intensive processes that you sort of put on hold until you maybe escape from a stressor. That's the maybe evolutionary advantage of that. All right, so that's the fasciculata. Then the innermost region of the cortex, right up against the medulla, is the reticularis. And this is composed of small, irregularly spaced cells. They have relatively sparse cytoplasm, and they contain a lot of lipofuscin, which you remember is a lipid deposition product. And the reticularis secretes primarily androgens. and that would be the main androgen is DHEA. And there are enzymes in the adrenal which can then sulfate the DHEA. They put an SO4 group on, and this makes it more water soluble. And so DHEAS is the primary form of DHEA carried in the plasma. The reticularis, I'll say, also makes a little bit of cortisol, more basal levels instead of the acute levels, which you see in the fasciculata. But the main action of DHEA is sort of as an anti-glucocorticoid. It has an anabolic function, which allows the body to utilize what cortisol has mobilized. So it protects against excess cortisol levels. It has, of course, androgenic effects, and that would cause growth of pubic hair, acne, facial hair, and so forth. In females, the DHEA is actually a source of estrogen after menopause, specifically E1 or estrone. So estrone is the main postmenopausal estrogen. E2 or estradiol is the main premenopausal estrogen, and then E3 or estriol is the estrogen of pregnancy. So DHEA can be mobilized directly into androstenedione, and then androstenedione is converted, aromatized via the enzyme aromatase to estrone postmenopausally. So after menopause, the adrenals really take over in females the roles of the ovaries premenopausally. And we'll look at that with pathologies, especially more functional problems where maybe inadequate regulation of the adrenals can really cause problems postmenopausally for people. Okay, so that's the reticularis. The innermost part of the adrenal, the core, is the medulla. This is not of mesodermal but ectodermal in origin. We can think of it really as an extension of the sympathetic nervous system as a specialized sympathetic ganglion. There are what I call chromaffin cells. The chromaffin cells stain dark because they have iron in there. Iron is a cofactor, remember, in the synthesis pathway between tyrosine and norepi and epinephrine. And the main secretions here of the adrenal medulla are epinephrine, about 80%. This again in the UK is known as adrenaline, and then norepinephrine, about 20%, which is known as noradrenaline also. And the main activator for release is the sympathetic nervous system for the adrenal medulla. The effects here are more catabolic. The effects of adrenaline really are to mobilize energy stores during acute stress. Now, unlike the cortex has to make its hormones on demand, so there's no storage of any of these steroid hormones in vesicles or anything like that. They have to be immediately synthesized and released, versus the adrenal medulla, you can store up the epi-norepi, and then it's going to be released when there's an acute stressor or an acute injury to the body or something like that. And then once it's released, it's going to take a little while for it to resynthesize. So you can get these bursts of adrenaline and then more of a crash of adrenaline and back and forth this way. One of the main effects of adrenaline is to work acutely to raise blood sugar. So you see high adrenaline or high epinephrine release during hypoglycemia. And that's what gives a lot of the symptoms of hypoglycemia, the shaking, the sweating, the rapid heart rate, and so forth. All right, so that's the adrenal cortex and the adrenal medulla. Okay, so there are three sets of arteries that provide blood to the adrenal gland. There are the superior adrenal arteries, the middle adrenal artery, and the inferior adrenal artery. And all these really come off the aorta, different places. So the superior adrenal arteries are branches of what's called the inferior phrenic arteries. They come off right above the celiac trunk. So remember, the celiac trunk is a major area in the solar plexus region. And off the celiac trunk comes all the little arteries that supply the pancreas, the spleen, the stomach, the liver, gallbladder, and the upper small intestine. So we have the phrenic artery, the inferior phrenic artery, and then the middle adrenal artery originates just adjacent to the celiac trunk off the aorta, and the inferior adrenal artery comes off the renal arteries on both sides. So very rich blood supply, and that's partly because the adrenals need a lot of energy to make these different steroids, and it's through the arterial blood that the majority of the cholesterol that the adrenals will use comes in, and that's in the form of LDL. So low density lipoprotein, we know this usually as the so-called bad cholesterol, but really what LDL is a lipoprotein to carry cholesterol from the liver to the different body tissues, and in this case, the adrenals. The venous drainage is on the left adrenal. It's through the left adrenal vein, then the left renal vein, and then into the inferior vena cava, versus the right adrenal drains directly into the right adrenal vein in the inferior vena cava. So slightly different, a little bit more complex drainage on the left adrenal. I mentioned this is one of those weird board exam questions you sometimes see. The lymphatic drainage of the adrenals, really they drain into the lumbar lymph nodes via the adrenal lymphatic vessels. And there are two lymphatic plexuses, one in the cortex, the other in the medulla, which drains the adrenal. So any adrenal tumors or whatnot would move through that lymphatic system into the lumbar lymph nodes. They'll all conglomerate into the cisterna chyli. That'll go into eventually the thoracic duct into the left subclavian vein. All right, so that's the arterial, venous, and lymphatic supply of the adrenals. The nerve supply is primarily via the sympathetic nerves. Not a lot of information on parasympathetic nerves in the adrenal. So it's the parasympathetics, and they originate primarily from the spinal cord at the level of T5 to T11. And they will go right into the adrenal. So normally with the sympathetic nerves, you have a preganglionic neuron, and then that synapses onto a postganglionic neuron. In the case of the adrenal, the preganglionic neuron, in its sort of termination, really, this would be the adrenal medulla itself. So there's no postganglionic neuron in the case of the adrenal cortex. And the medulla then secretes catecholamines directly into the blood. Again, primarily epinephrine, a little bit of norepi. Norepi, remember, is the primary neurotransmitter at the postganglionic neurons in the sympathetic nervous system. Now there are both, so this is the sympathetic efferent nerves. There are also sympathetic afferents and some parasympathetic afferents that come from the adrenals, and they're going to feed back up into the spinal cord and then into the brain. We're not exactly sure what those afferents do, but they probably are having a sensory function on the adrenals. Very interesting to look at the limbic system area of the brain. We usually correlate that with the emotional brain. But one interesting idea recently is that the limbic system is really a map of the different organ systems. And so we have afferent, parasympathetic, and sympathetic fibers bringing organ information and glandular information up to the limbic system where it's mapped. And so we might argue that this is really not the seat. The limbic system is not the seat of our emotions, but it's really where we become aware of the patterns in our organs and our glands, physiologic patterns, which are directly tied in with the emotional life. So really, our emotions are more embodied, and the brain is where we become aware of those emotions. That's one hypothesis there. One correlate of that is that the amygdala, which is our fear centers in the brain, when we trigger that, the amygdala, that tends to exacerbate anxiety and fear responses and so forth. One hypothesis is that the amygdala actually are receiving inputs from the kidneys, but specifically the adrenals, into the brain. So they are where that adrenal information is being mapped onto the amygdala. Well, that's curious because in Chinese medicine, there's a connection with the organs and different emotions. This is also true of many traditional medicines. In many traditions, the kidney system, including the adrenals, is linked to the emotion of fear. And of course, in fear states, we release lots of epinephrine, and we activate the adrenals, and that could very well also activate the amygdala. In fact, we know with chronic hypercortisolism and so forth, it actually over time damages the amygdala. And this is what can lead to not just anxiety, but depression as well. And one interesting finding is that low doses, or the typical therapeutic doses of SSRIs, like Prozac and Zoloft and whatnot, that these drugs actually over time protect the amygdala from the excess cortisol and potentially epinephrine as well. So one interesting connection there between the body systems and the different places in the brain. All right, so that's the general nervous structure of the adrenals. Finally, I just want to say a few things about the embryology of the adrenal gland. Again, the cortex and the medulla have different embryonic origins. In the fetus, the adrenals are first detectable after the 6th week of development, and they weigh about 1 gram at birth, but they're going to grow up to 4 grams in total. The adrenal glands in a newborn are much larger as a proportion of body size than in adults, so the adrenals actually comparatively look very large in newborns. At 3 months, they're about 4 times the size of the kidneys, and then gradually the cortex shrinks. It almost disappears by the age of 1, and then it's going to grow again after the age of 4 or 5. So it kind of goes through a devolution and then an involution, and then it expands again. The cortex is derived from intermediate mesoderm. Again, mesoderm is the main tissue giving rise to your cardiovascular, renal systems, musculoskeletal system, really all the structure of the body. Appears about 33 days after fertilization, so just over a month, and it can produce steroids by the 8th week. In the first trimester, it really undergoes a rapid proliferation under the influence of ACTH from the pituitary. So really within, by the 2nd month, going into the 3rd month of embryonic development, the adrenals in the fetus, in the embryo, are putting out lots of hormone. The fetal adrenal, though, only has 2 layers. There's an inner fetal zone, which primarily produces the DHEA sulfate at a rate of about 100 to 200 milligrams per day. Now, the DHEA will be aromatized primarily for estrogen, and this is going to be used heavily in the placenta for placental development. The adrenal will then decrease in size after birth with the decrease in the androgen production. The outer region of the adrenal cortex in the fetus is called the definitive zone, and it secretes primarily cortisol. Now, one really important role of the fetal adrenal hormones is to essentially stimulate lung maturation. So one of the signals to develop surfactant in the lungs is adrenal steroids. So adrenal is very important for lung maturation and development in the fetus, but even in the adults, we know that the adrenals play an enormously important role in regulating lung physiology. One example of that is asthma. We usually think of asthma as a lung issue, but interestingly, the way we treat it, both biomedically and through traditional medicines, is via the adrenal system. So if you look at the main treatments for asthma, we use, of course, the acute-acting bronchodilators, and these beta-2 agonists really mimic epinephrine and norepinephrine, and they act at the same receptors. And then we also use inhaled corticosteroids, which are mimicking the glucocorticoids and DHEA. So those are extremely important for maintaining normal lung function, even in the adult. For a lot of chronic pulmonary diseases, DHEA has a definitive role. There's a lot of research on that. A lot of herbal therapies, especially what we might call the more stimulating adaptogens, like the Panax species, Eleutherococcus, rhodiola, schizandra, licorice. All of these can increase DHEA secretion and thereby have a protective effect on the lungs. And they're used in a lot of traditional formulations, both in Chinese medicine and other traditions, to protect lung function. Adrenarche or adrenarche is really the time when the adrenals come online just before puberty. This really is a early or pre-stage of sexual maturation. The zona reticularis, that zone that secretes the DHEA, begins to enlarge, and the adrenals begin to secrete increased androgens. DHEA, DHEA sulfate, and then some androstenedione, which is another androgen. And this occurs without an increase of cortisol. It occurs in both higher primates and humans, starts around the age of 6 to 8. So that's when the adrenals really come online, especially for the DHEA. And it peaks around age 10 to 14, so just before puberty. It's related to puberty, but it's distinct from the development of the hypothalamic pituitary gonadal axis. So it's independent of the LH, FSH secretion from the pituitary. So it precedes puberty by about 2 years or so. And this results in increased pubic hair, body odor, skin oiliness, and acne. So this often occurs before puberty actually occurs. So that's adrenarche. And then adrenopause would be a decline in the secretion of adrenal androgens. We don't talk much about that, but we do know this is really important. The peak secretion of the DHEA in particular is around age 20 to 25, and then it declines by about 2% per year. And the levels in an 80-year-old are only 10 to 20% of that of young adults. And it's caused by an involution of the zone of reticularis. And so, interestingly, after 60, 65, you start to see all sorts of things: increased cancers, increased risk of pulmonary disease, especially pneumonia, with infections like the flu viruses, coronaviruses, and so forth. One interesting question is, could DHEA be helpful in those cases? Because we know across the board that people's DHEA levels are generally lower at those ages, and so there's less lung protection from that. So that's adrenopause. And then the adrenal medulla, again, embryologically is derived from the ectoderm. This is the same tissue that gives rise to your nervous system, and it forms primarily what's called the neural tube in embryonic development by the 3rd week of development. And then outside the neural tube, there are these little cells called the neural crest cells, and they're going to form the peripheral nervous system and the autonomic nervous system, including the sympathetics, and here the adrenal medulla. There's various bone morphogenetic proteins, and cortisol also help to stimulate the development of those nerve pathways in embryonic development. Okay, so that's a little bit about the adrenal embryology. So that's going to wrap it up for the general anatomy section. In the next little video, we're going to go into the physiology of adrenal hormones.